Welcome to our NP Seminar series. I thank you all for coming in person and to those of you online for joining us. Just a few announcements before we introduce our speaker. So just as a reminder, we do have Thursday morning monthly PI meetings. Thursdays, 8 a.m. I encourage all of you to join. If you're new to the FES Center, it's an opportunity for you to see what the FES Center is all about. And for those of you who've been to the FES, who are part of the FES Center and don't come, it's an opportunity to re-engage with our community, myself included. So please come to those. There are a number of initiatives that we have as the FES Center, one of which this Saturday is the Cleveland Pain Symposium, put on by the Cleveland Clinic Consortium for Pain, Case Western Reserve University, and the FES Center. Registration is still open. It is this Saturday, April 12th and 13th at the Health Education Campus on Euclid. So I encourage you to consider attending if you have not signed up. We have a number of seminar series, a number of seminars that we put on, one of which is the First Tuesday seminar series. This May 7th will be visited by Dr. Dennis Bourbeau and Dr. Punit Vaidya of the Cleveland VA Medical Center, Case Western Reserve University, and Metro Health Medical Center. I encourage you all to come to this laid-back opportunity to see many of the really interesting scientific investigations of investigators as part of the FES Center. Of course, we're here to see our distinguished speaker as part of the Neuroprosthesis Seminar Series. This series is really an opportunity for us to invite nationally and internationally recognized speakers and scientists and investigators to join us in Cleveland. We've had people like Dr. Andre Machado, Dr. Doug Weber most recently, today Dr. Emery Brown, who I'll introduce in a minute. And May 16th, we'll be joined by Dr. Vivian Mouchouar from University of Alberta. So I encourage you all to keep that on your calendar as well. Okay, so without further ado, it is my distinguished pleasure to introduce our speaker, Dr. Emery Brown. Dr. Brown is the Edward Hood Taplin Professor of Medical Engineering and Computational Neuroscience at Massachusetts Institute of Technology, and also the Warren Zapple Professor of Anesthesia at Harvard Medical School and an anesthesiologist at Massachusetts General Hospital. He received his bachelor's in applied math from Harvard College and his master's and PhD in statistics from Harvard University and his MD from Harvard Medical School. He completed his internship at Brigham Women's Hospital and his anesthesiology residency at MGH. He's received numerous awards, way too many to name. He's a fellow of IEEE. He's part of AAAS, American Association for Advancement of Science, the other AAAS as well, American Academy of Arts Sciences. He's part of all three national academies, including National Academy of Inventors, National Academy of Sciences, Engineering, and also part of the American Philosophical Society. 2020, he received the Swartz Prize for Theoretical and Computational Neuroscience. In 2022, he received the Gruber Neuroscience Prize. He's received numerous other awards. He's an innovator, an educator, a mentor, world-renowned for his contributions to neuroscience and anesthesia. It's our distinct pleasure to have you, Dr. Brown. With that, I welcome you to the stage, and we look forward to your talk.
It's a tremendous pleasure to be here with you. Thanks so much for coming. And I really want to thank Bolu for arranging all of this. I've had a fantastic time visiting, and I've learned a tremendous amount. I was telling Bob I was taking notes copiously as I was talking with everybody today. So thanks for having me. So I'm going to talk about general anesthesia, neuromodulation, altered states of arousal. These are some of the funding sources I've had the good fortune to have: NIH, my Department of Anesthesia at Mass General Hospital, and the institutes to which I belong at MIT. I'm going to follow this outline. I'm going to talk first about anesthesia-induced slow delta oscillations. Then I'll share with you some other what I call anesthesia factoids, kind of things about anesthesia that every sort of just well-educated person should know. Closed loop control of anesthesia, and then in the end I'll talk about reanimation, turning the brain back on after anesthesia. So what is general anesthesia? It's a drug-induced reversible state That's comprised of antinociception, meaning you can't process pain information, nociceptive information, unconsciousness, amnesia, akinesia, and stability and control of the physiologic systems. And the reversible is important because without that, these other guys here, these guys here by themselves, that would be death. All right. And that's not cool. All right. So, and I started this right here because when we wrote this original article back in 2010, we didn't say this as cleanly. I said analgesia, but it's really antinociception because you're unconscious and the pain information is still being processed as opposed to pain, which is actually conscious processing. All right. Little technical point, but important. And it's often said it's not clear how anesthesia works. And I want to just say it's no mystery. An important mechanism to which the drugs work is by creating oscillations which impair how the parts of the brain communicate. And I'm going to show you that in several examples today and show you how they differ across drugs and some other physiologic conditions. So let's talk about the anesthesia-induced slow delta oscillations. So to begin this, I want to go back in history a little. So this is a schematic that represents some classic experiments that were done by Frederick Breme. He was a Belgian neurophysiologist. And the first thing he did was, in a series of cats, he severed the brainstem, so just about below the medulla, from the spinal cord at A. And he saw an EEG that looked like this. And he called that the encephale isolé, the isolated encephalon. And it looked awake appearing, basically. And then he did a second set of experiments at B there, where what he did was he separated most of the brainstem from the brain, at least certainly the cerebrum. And when he measured the EEG in this case, he saw these slow delta oscillations, and he called this a cerveau isolé. So a cerveau in the sense of cerebrum here. And so this was one of the first set of experiments that gave us the idea that there's something in here that's important for arousal. And now we know that, many of the arousal centers are placed there in that sort of lower part of the midbrain, pons, and the upper part of the medulla. So the reason I'm showing you this is to just make a general statement. People are wondering, like, what kind of things do anesthetics have in common? One of the things is that they all have targets in this area. All right, so they'll all produce slow oscillations, but they'll be mechanistically different. All right. So just to start this off, let me show you this little video here. So this is a woman I took care of several years ago who was coming for thyroid surgery. She's about 60 years old. She weighs about 80 kilos. And I'm going to give her a bolus dose of propofol, 150 milligrams. And I'm just going to play this in real time. So we'll see how she. This is her EEG. So we can put 4 leads of EEG on every patient that we take care of. And so this is what this looks like. I'm going to play it. Right. So you can see the 4 leads there. And in a second, you're going to see it get really noisy. And the reason it's going to get noisy is that, you see it there. Because when you inject propofol into a small vein like this one on the back of my hand, it burns like crazy. So she's doing this. We're saying just bear with us, just bear with us. You can see she's really tensing up there. And that's actually going to be good from a pedagogical standpoint because you're going to see the instant that the drugs take over. Watch right here. Boom. Beta oscillations. Slow oscillations. Little deeper slow oscillations. Now she's going to go flat and then burst and then flat and then burst. So when you saw those slow oscillations come on the first time, she was completely unconscious at that point. And so let me just sort of recap what I just showed you. So when she was awake, she had oscillations which were, about 5 microvolts or so. And they're high frequency but low amplitude. And these are the gamma oscillations. This is where we typically carry out our communications. And then what you saw was, we'll skip over paradoxical excitation. We saw her come down to this state here, this sedative state, where we had these very regular kind of beta oscillations. So if I wanted to have her in a state so that she could have a colonoscopy, she just needs to be sedated, I would titrate to propofol until I got to the state, and I would just keep it there. And then we skipped over this. We'll get to that in a second. We went right to here, these very large, slow oscillations, which are at about a little less than 1 hertz. And this is very typical of propofol, and it's typical of GABAergic anesthetics. Then you saw her go in a profound state of anesthesia, which is flat burst, flat burst. This is called burst suppression. This is essentially too deep. You know, she's deeper than she needs to be. And then between the bursts, she's actually flat. So the area, the state that we try to get to, so all these states from here down to here are also seen in states of coma. So it makes sense that anesthesia is a drug-induced reversible coma. And so we want to get to this state here. This is as far down as we need to be without being sort of too far, where you can see the slow oscillations and these alpha oscillations riding on top. So I just want to tell you, first of all, how does propofol produce its slow oscillations? So this is what it looks like in the operating room. So across time, in this axis here, this is me taking care of a young woman who was having a procedure that for which she was sedated with propofol. So this is the spectrogram. So looking at the frequencies across time. So here's the frequencies over here, time on this axis, and the colors basically in decibels tell you how much power is in a given band. So you can see she has a lot of power here in like the 10 hertz band. So the propofol started here, then maintained on an infusion. So you see the slow oscillations and the slow and delta oscillations, so about 0.1 to about 4 hertz. Then up here you see something about, let's say, 10 to 12 hertz. This is the alpha oscillation. So that is the state right here. That's what it looks like in the frequency domain. And as long as I keep the propofol running, she's going to stay in that state. And this is the classic signature of propofol for a young person. All right. But then I can draw a diagram like this, and I can think, so propofol works by enhancing GABAergic inhibition. So it's going to go to interneurons everywhere throughout the brain, the central nervous system. And so I've just drawn some in here. So these are cortical interneurons, and here's the very important sort of reticular thalamus, which is a major inhibitory network. And then down here in the brainstem, all right, down here in the brainstem, there's a very important inhibitory network. It comes out of the preoptic area of the hypothalamus. And it's just like I've drawn it there. It's like this. It's like my wrist, all right? And it has these projections which come out like this, which are inhibitory. So these projections here are GABAergic. So propofol comes up along here to get to the brainstem, in the brainstem, comes along the basilar artery and hits these sites here, and that's when the slow oscillations came on. And if we'd done a clinical exam on her at that time, checked her oculocephalic reflex or checked her pupillary, they would be totally gone, suggesting that there's a brainstem effect. Now, it's also hitting these other areas simultaneously, but this is just to point out there's a tremendously strong brainstem effect. So let's just talk about this a little bit more, because this is something that we've had the good fortune to study over the last several years, thanks to our neurology and neurosurgical colleagues at MGH. So this is work from Laura Lewis's PhD thesis. So what she did was a really cool experiment of nature. As you know, the patients that have epilepsy get grids or strips or stereoelectrodes implanted, and they stay in the hospital for a few days. They seize off of medications, and they're brought back to the operating room to have the grids and strips removed or the stereoelectrodes removed. And then at that time, you have a natural experiment you can take advantage of. You can just record the data as someone becomes unconscious. So if you look here, this is this patient awake. So these are 3 areas. The spots correspond to the locations of these local field potentials here. So there's the spiking activity. This is a neuron which is sitting next to the red local field potential. And you can see it has this very dysregular, what's called a synchronous pattern, so wide awake. Now look what happens here when the patient is unconscious. You see slow oscillations like this. They're like this, like this. And it's also important to notice that you don't see the alpha oscillations. Those are more a frontal phenomenon, and they're not seen sort of in the medial temporal lobe. But you can look at them and you can see that the spiking activity is now set out, at least at this neuron, like every 2 seconds or so. All right. So I don't know how much you have to slow down to not be able to be conscious, but I submit to you, this person is probably not conscious in this state here. And I'll get right to the point. The good thing about that, knowing that, is that when I see the slow oscillations, and I know they're generated by propofol on my spectrogram back here, I can know she's profoundly unconscious. So it's interesting scientifically, but it's practically important for me taking care of a patient in the operating room. And then just to push this a little bit further, we did some parallel experiments in non-human primates, thanks to Earl Miller and his postdoc, Andre Bastos, and our joint MD PhD student, Jake Donahue. So we recorded from 4 areas. So area 8, so the frontal eye fields, prefrontal cortex, posterior parietal cortex, and superior temporal gyrus. So 2 kind of frontal regions and 2 kind of more posterior regions. And these are the neurons as they're spiking when we see these oscillations here. So this is like the monkey, wide awake. And then here's the spiking activity. So just to quantify this, the spike rates here are about 10 to 12 spikes per second. All right. And now look what happens over here. There are those large slow oscillations again here, right? And now look at the spiking activity. In fact, it actually all lines up across the 4 cortical regions, and you have these large sort of down periods. So there are 2 characteristics of this. The spiking activity is dropped, and there are these large periods of no spiking. So again, I don't know and to quantify this, the spike rate here goes from about 10 to 12 spikes per second to here, it's about 1/2 to 1 spike per second. So 95% drop in spike rate. So I can watch this by watching the slow oscillations on the EEG. Again, so I can feel very comfortable that a patient showing these characteristics would be unconscious. And the reason I'm harping on this is that one of the things that anesthesiologists are paranoid about is having awareness under anesthesia. And well, let me just tell you, it's not a public health menace, okay? It happens like 1 in 20,000 cases. But when it does happen, it's like, oh, they still can't tell how these drugs work or when someone's unconscious. But using this, you certainly could. So let's talk a little bit about ketamine. So ketamine has much different dynamics. So if you look here, this is work from Indy Garwood's PhD thesis. She was collaborating with Suresh Chakrabarty, one of my postdocs. And so if you give someone ketamine, like the low dose of ketamine that's currently used to treat depression, you're going to see an EEG pattern that looks like this. Very fast oscillations about gamma or so. So it's about 30, 40 hertz or so. When you give someone a dose of ketamine so that you can induce anesthesia, and you can use it as a single drug because it makes you unconscious, and it actually it controls nociception. So it's really truly an anesthetic. So look right here. You can see the fast oscillation and slow, fast oscillation. You can see it really well on the spectrogram here. See, there's a fast, slow, and it cycles back and forth between this every about 4 to 10 seconds or so. All right. And then so again, just following Bremé's principle, I should be able to look down here in the brainstem and find some targets the ketamine is hitting. So one of the things that makes the ketamine process so challenging or more complicated than just simply a drug that binds down here to the, it's an NMDA antagonist. So a drug that would just bind down here is that ketamine has to get into the channel to work. And so what it means is it can leave, you can generate several different states, blocked states, unblocked states, in addition to just having the drug actually binding at different receptor sites. So that adds that's what's one of the things that underlies the complexity of the rhythm that we see here. But we have targets here that they're hitting. So coming out of the myopontine reticular formation and also the parabrachium, these are glutamatergic, the NMDA circuits, which is probably where propofol is acting in the brainstem. And just to show you this a little bit more, so again, we did the same thing. This first diagram that I showed you here, this is human data. And so we did similar experiments in the non-human primate. So recording for several hours. And here's a little swatch of time here. So the ketamine was given back here, and you can see the 2 oscillations. So there's the faster oscillations here, the slower oscillations. And if you take this strip right here and just blow it up. So what Indy ended up doing was constructing a hidden Markov model, because the activity doesn't go fast, slow, fast, slow. It actually goes slow, a little faster, fast, slow, a little faster, faster, like fast. And you can see that right here. There are about 4 states in our hidden Markov model where it's slow and increases, slow and then increases. It's highly structured dynamic that you're going through. And if you measure the spike rates, if you just measure the spike rates on this person here, the spike rates are still at 10 cycles per second, 10 hertz, basically. It's spiking just as at the same rate as if the person were awake. But the key thing is that the dynamics of the brain are different. And that's why the person is unconscious and also insensate in this particular case. And one other little point on this, if you look here, so about 50% of the time, all 4 areas are in sync. About 70% of the time, the 2 posterior areas are in sync. And then about more than 80% of the time, the 2 posterior areas the 2 frontal areas are in sync. So just like I showed you with propofol, there's also this very strong synchronization which is going on across, so within neighboring regions and so as well as with regions across the entire brain. So again, these sorts of states, I submit to you, it would be very hard to be conscious when you have these states on your EEG. So I put this in just because I wanted to put it in. But Ezra Marcus wrote me a few years ago, and he was writing an article for the New York Times about the increase in people getting high on nitrous oxide. Okay, do not do this. This is dumb. All right. So, but what he's doing is, you can see he has this canister of nitrous oxide. He's got it hooked up here to a mask, and you're sniffing it, and you get a high. I mean, it's well known. Let me tell you something else about this. In anesthesia, we have this thing called a single breath induction, where with young kids, you can't put an IV in them, so you have to have them go off you have to have them become anesthetized by having them breathe anesthetic gases. So what he's doing here is what we do to kids. We have them just go. And by the time they take their second breath, they're completely out. So he could kill himself right here, basically, because he could have a respiratory arrest and be nobody there to resuscitate him. So this is not cool, all right? But the other thing I want to show you about this is this. This is your brain on nitrous oxide. I mean, look at those oscillations. It's the same monitor. I mean, they look like perfect sine waves. I mean, so you definitely do not want to go around sniffing nitrous oxide, all right? Because this is not compatible with being conscious. I can assert to you that, all right? All right. And what's really, really interesting about it is, so here I have a patient on sevoflurane. I haven't told you about the pattern, but it's a pattern similar to propofol. It's one of the ethers that we still use. So, and then right here you can see we switch over from isoflurane to nitrous oxide. So this is the ether, isoflurane. And we turn the nitrous up, so it's about 60 or 70% nitrous. And then slowly but surely, see how it breaks, and these slow oscillations come on here. And this is what they look like, just like that. Now what's really interesting is they don't stay. They actually disappear. After a period, they convert into high frequency oscillations, gamma oscillations. And I have no idea why that occurs like that. But and I'm probably not going to study it because we're not studying the gases because they're not friendly to the environment. But again, it has targets, pure targets down here in the brainstem, the same NMDA targets that probably propofol is hitting, except it doesn't have the complexity of the channel, the channel dynamics as part of its mechanism. So, and one final point. This is dexmedetomidine. Very often people ask me, what of the anesthetics comes closest to sleep, generating sleep? And dexmedetomidine is it. So when you administer dexmedetomidine, you'll see a pattern that looks like spindles, like right here, and then slow waves. It looks very much like non-REM stage 2 sleep. So you can see the spindles right here, and then more spindles. And then if you give a larger dose, you'll get large slow oscillations, just like slow wave sleep. And this is no accident, because part of what dexmedetomidine is doing, so it blocks the areas that are receiving noradrenergic input from the locus coeruleus. So the locus coeruleus is the only source of like norepinephrine in the brain. And it has 4 projections. Projects the cortex diffusely. It projects here to this preoptic area, the hypothalamus. It projects the central thalamus, and it projects to the basal forebrain. Now, this projection here is a key, right? Because what it does is during the day, what the locus coeruleus is doing is keeping that inhibitory network inhibited. So now if you block that the inputs, the norepinephrine inputs to that inhibitory network, the inhibitory network is released, and you get the slow oscillations like right here, like I'm showing you. So it's very clear why this happens. And this is also, the reason this is important, the activation of the preoptic area is one of the mechanisms through which we fall off to sleep. And it's like you're decreasing directly the excitatory inputs going to cortex. So a very clean way to go off to become unconscious, I think. And just a few other little factoids. So kids who are less than 3 months of age have only slow oscillations. They don't start to produce alpha oscillations until 4 months of age. And we think that this is due to the fact that the thalamocortical connections haven't sufficiently formed. Our thesis is that the alpha oscillations are a thalamocortical oscillation. We have mathematical modeling evidence of that and also experimental evidence of that. The other case where you just get slow oscillations are just in older patients. As we get older, we lose our alpha oscillations, so we just have slow oscillations. And we'll talk about why that is in just a second when I show you another case. And then also, in patients that have overwhelming sepsis, this is a gentleman who had a necrotizing wound to his arm. He had been shooting up. And he had to come to the operating room every few days to have his dressing changed. And I asked the nurses before he left the ICU, what does his EEG look like, or how awake is it? Well, we don't know. So I was dying to put the EEG on him. And this is what I saw, just these slow oscillations. And it floored me, because I was expecting to see, remember the young woman who had the nice slow oscillations and the 10 hertz oscillations here? I expected to see the same thing in him. We didn't see that. And then we came to learn that this was a very typical pattern from patients coming out of the ICU. And then trying to put it together mechanistically, the inflammatory mediators actually do bind to the arousal centers. And some of them can actually inactivate the arousal centers. Mark Ott, who's a neuroscientist at University of Washington in Seattle, has basically shown that. So that's probably what's happening to this gentleman. But the conjecture is, if once his inflammation is resolved, his alpha oscillation should come back, all right? So we finally got evidence of that. So this is a patient that we were taking care of, this Christian was taking care of during COVID. He's one of our fellows, our ICU cardiac fellows. This is a patient, you can see his lungs are totally whited out from the ARDS pneumonia that he has here in the earliest day 0 of COVID. So day 0 here, this is his chest x-ray, here's his EEG, just slow oscillations. And look over here on day 3, when his lungs have cleared up, the inflammation has been reduced, his alpha oscillation is back. So he has the capacity to produce it, but it's being altered by this inflammatory state. So just some other factoids which you should know, all right? So the brain response to anesthesia changes dramatically with age. So this is the 30-year-old again. So classic picture of propofol, you can see the 10 hertz oscillation and the slow delta oscillation. And then here's someone who's 57. So this guy here could be her dad or his dad. And so look, you see the 10 hertz oscillation, and it actually shifted down a bit. See how hers is a little higher up? It's actually shifted down. This is what happens as we get older. But you still see the slow oscillations, and the alpha oscillation is very evident. Now here's a lady who's 81 years old, all right? This is a woman I took care of who had a tumor on her chest the size of an American football, and it took the thoracic surgeons the better part of 6 hours to remove it. But I was able to give her, essentially reduce the dose of the anesthesia that I was giving her, the propofol infusion, by like 70%, because I'm watching the EEG and I can see she has very weak alpha oscillations and slow oscillations. Now here's the part that's a little sobering. These two guys are roughly the same age. His EEG looks like hers, and his EEG looks like his, all right? And you know, we age different physically. Our brains more than likely age differently as well. And you know, who would think that you see it under anesthesia? Well, one thing is, actually, you know, there used to be this commercial on television about Clairol hair coloring, and they say only your hairdresser knows for sure. So maybe only your anesthesiologist knows for sure, like how bad your brain is, right? But what's occurring here is that in this particular case, this gentleman here has lost his alpha oscillations, and and the reason it becomes more evident, you could probably pick this up on EEG before people came to the operating room, but anesthesia amplifies everything. You see, it makes it so the oscillations get to be bigger, so this makes it more readily visible. And you can guess what the kids look like. So there's a 3-year-old, there's a 14-year-old, all right? The same patterns, the same dynamics, but with over a much broader sort of frequency bands. And this is why these indices that were built here for adults using data coming from people in this age cohort didn't work in children, because at areas here where you're supposed to have no oscillation power whatsoever, or like up here in this particular guy, the kids are have tons of it. And so you can see that the pattern is declining over time. And, those of you out there who are the 20-somethings, don't get too smug, because it turns out the peak is between 6 and 8 years of age. So you're on the decline too. All right. But it changes very dramatically with age, the anesthetic response. General anesthesia is not sleep. Just want to make that clear. I mean, we often say to patients, Mr. Jones, I'm going to have you go off to sleep for your operation. Because if I said I'm going to put you in a drug-induced reversible coma, you'd probably hop off the table, all right? But what I do is I say, Mr. Jones, you're going to be unconscious. You won't feel any pain. You won't remember what happens to you. You won't move. It'll make it easier for the surgeons to operate. And I'll be watching your heart rate, your blood pressure. I've just given him a lay definition of anesthesia. And it's much better to speak frankly like that than to try to use metaphors which are incorrect. Because think about it. Suppose anesthesia and sleep were the same thing. What would you do? You wait till people fell asleep. He's asleep. You'd rush him down to the operating room and let's operate on him while he's still asleep. Obviously, we don't do that, because it's nowhere near a profound level of brain inactivation as anesthesia is. So look, here's anesthesia. We bring you down to one of these states and we hold you here. But what is sleep? We start here, we go through the REM stages, non-REM stages, we go up to REM, non-REM stages go up to REM. We do that about every 90 minutes, 4 to 6 times a night. We typically wake up from REM, and we also have microarousals around the time we have REM. So this isn't definitely not that. And you can basically see it in the EEG dynamics as well. All right. So let's talk about closed loop control of anesthesia, specifically unconsciousness. So these are 3 very well-known people who had head injuries, and they were actually placed in a medical coma. So what's a medical coma? A medical coma is a profound state of brain inactivation where you usually administer a very substantial dose of one of the anesthetics like propofol, and you put them in a state of burst suppression. And we saw that originally. This is the burst suppression. We actually saw in the video the woman go into burst suppression. She goes flat, and she bursts, and she goes flat. All right. So you use it for when patients have head injuries, and when people have intractable seizures, we'll anesthetize them because all the other drugs that the neurologists have tried don't work. All right. So the final sort of the final therapy is actually placing a person under general anesthesia, and it may take several days for the seizures to break. And that's what we call a medical coma. So this is done just by kind of eyeballing the EEG, kind of guesstimating where the rates of the infusion of the propofol should be. So one of the things that one of my grad students and postdocs, Miriam Sunichi, studied was if we could build a closed loop control system to do this. It makes sense. You're going to be there for days. Why not let the technology help you out? So a very obvious construction. So you decide what target level you want the propofol to be at, or how unconscious you want the person to be, and in this case the animal. So the controller goes to the syringe, which controls the flow of propofol into the animal. You read the EEG signal, you process it, and then you come back out with the estimated value. So here's the marker where you want it to be. Here's the difference, and based on the difference, you change the rate up or down. Standard control, nothing out of the ordinary. The thing that we used for the control signal was this burst suppression pattern, because it's very easy to quantify. Like if you look at this, this is, you know, you're suppressed here, you're suppressed there, you're bursting here. So if you took this as about 1 second or so, then this is about 60% suppressed. So we can easily set a target and define unconsciousness in this way. All right. So that's what Miriam did. So let me just show you this. I'll just play this. Play this video. So you're going to see a target come on, a green line. So there's the green line, all right? So 0.7. So that's what and this is what the controller's doing to keep it at 0.7. This is the raw EEG coming in, and this is the pump rate in order to keep the controller at 0.7. Sorry, 0.4 is where we started. Now he's going to raise it up to 0.7. There we go. Boom. And you saw there was the pump gave a good bolus, and now it's actually flowing at a higher rate than it was here. And you can see the EEG starting to come down. It was up here, mostly there, and starting to come down here, which makes sense because here you have more suppression. Now it's going to go up to another level, 0.9, so it's 90% suppressed, all right? And you can see it tracks it. It tracks the level really well. So closed loop control is very, very feasible. So this is more than 10 years old. So we had a conversation with the FDA after these results, and they said, you know, Emery, that's really cute, but you know, we need to see this in larger animals, all right? So that led us to, actually, before I tell you that, just to show you, one of the things that Miriam did was she actually did a whole different set of patterns. I've shown you the one going up, going up, going up, but I would just want to show you one of these. Here's one where you go up and then you need to come down. So to come down, we don't have a drug that decreases burst suppression. So what the controller does is it shuts off. It shuts off until it drops back to the level where it wants to be, then it comes back on again, all right? So this shows it was feasible, and as I said, this is more than 10 years old. So they said we needed to do the studies in larger animals. So with the help of Earl Miller, we set up a protocol to actually study this in non-human primates. And this is work that Suresh did with Jake. And again, the same sort of idea. You have a target level you want, you have the target level you estimate from the EEG, in this case the local field potentials. The controller controls the infusion rate into the animal. And then and actually this one here, the duty cycle, the update was every 20 seconds. And the one I showed you in the video was every 5 seconds, all right? This is a little bit slower, but we can make it whatever we want. Now here's the bit of science that pushed it forward. So we need a marker of unconsciousness. That's what MOU stands for. So if you look right here, remember I showed you that when the spike rate went down, the animal was probably profoundly unconscious. So I can track that because look how it runs in lockstep in the non-human primate with the power in the 20 to 30 hertz band. So if I track this, I'm basically tracking this. So if I know if I'm controlling this, I'm basically also controlling this. So this is where the eye is closed and this is where the eye is open. So we're going to use the power in the 20 to 30 hertz band as the marker of unconsciousness. So Suresh set this up. So he wanted to keep the animal at 1. So 1 is the target he set up for first. And what we're going to do is we're going to imitate what we do in the operating room. We're first just going to give it a constant infusion. We'll do that for about 35 minutes or so. So you'll see this is a constant infusion. And you'll see how the marker wanders here. Then we're going to, after about 30, 40 minutes, we'll let the controller take over. So I'll just play this. And that's the EEG on the bottom. So here you are. You can see it's wandering all over creation. The infusion rate is nice and constant. And now watch what happens here. The controller is going to take over. Controller takes over. Now it locks it into 1 where it should be. It's holding it right where it should be. And then what I think he's going to take it down to a deeper level in just a second here. So he's going to drop it. So it drops it down to here. Moves down, no problem. And he's going to move back up a little bit higher than what he was before. There we go. So, I mean, it's no surprise to this crowd that something like this would work once you have the right marker. And so that's what basically needs to be done. But I want to show you something, because this actually teaches us an important, I think, lesson clinically. In the OR now, we run constant infusions like this. And look what happens. The person just gets deeper and deeper and deeper. And look at what the controller did. It actually shut off for 3 minutes. It shut itself off and then came back on, basically, once the marker had drifted back up to the target. So it's very easy under these constant infusion routines to overdose patients. And that's certainly what we're doing in the operating room now. And so we did this, for 2 animals over 9 sessions for about 19 hours. And we just published this last spring. Different patterns. And so this illustrates that it works. So now we have a chance to talk to the FDA again and see if we can try to do some studies like this in humans. So reanimation. So we don't give you drugs to turn your brain back on after anesthesia. We give you drugs to anesthetize you, but what we do is we just let them wear off. And so how you come back is very much dependent upon you and how much drug you've gotten. So there's nothing like sort of to try to wake you up. And as we had a long discussion this afternoon, for animals, particularly horses, and even the monkeys, when they're doing surgeries at our place, they actually get a reversal agent to reverse the anesthesia. So why not do that for humans? All right. So here's my colleague, Ken Salt. He's been working on this for a while. And this animal, this rat, has a propofol infusion running into its tail vein here. And what he's going to do is he's going to stimulate his ventral tegmental area to wake him up. And you're going to see the animal's going to get up and come out of the anesthesia. All right. So he hasn't started the stimulation yet. You can see the propofol is white, so that's it running into his tail vein there. And you can see him breathing here. So stimulation's aimed at the VTA. He turns it on now. Right here. Now watch how his breathing increases immediately, right there. The propofol is still running. So whatever is happening is like counteracting whatever the propofol is doing. And he gets up and says, look, I'm out of here. All right. So what's he doing? All right. So I showed you that he's awake, right? But can he process cognitively? We want you to not only just be awake again, but we want your brain to work. So Ken did another set of studies where first what he did was he trained the rat to execute a task. Like it might hit the correct light, it can turn around and get a reward. Hit the correct light, turn around and get a reward. If it hits the wrong light, it gets a warning sign that tells it that that's wrong. So what he did was he trained the rat to do that first. Then he did the very similar experiment, this time with isoflurane, anesthetized them. So when the animal wakes up, he's going to wake up and start executing the task, all right, showing that he's actually cognitively intact. And then what Ken's going to do, he's going to wake him up by stimulating his VTA again. But then what he's going to do is turn the VTA stimulation off, and the animal's going to go out, all right? So let me just show you that. So there's the animal in the box. There's no stimulation. He's on isoflurane. It was 0.5%. Ken's going to turn the stimulation on. Right there. So he comes to, all right? And he looks, so that's where the food is, but there's no free lunch. He has to work first. He has to hit the light. So he hits the correct light. He turns around and gets the food. Remember, the anesthesia is still running. We haven't turned it off. So he turns around again, a little wobbly, hits the correct light. But he's cognitively processing. He's doing what he was trained to do. All right? And I think he turns around this time. I think he gets this one wrong. So he looks up, he hits, yeah, so that tells me it was wrong. So there's no reward. Now what he's going to do is going to turn around again and start to work. And Ken is going to turn the stimulation off. And he's out again, all right? So showing that, what we're trying to do is develop ways that we can, modulate up as well as down, right? And so this is just some of the first attempts at it. And so what's Ken doing? So he's done this with drugs also, with Ritalin. And remember, here's this pathway, the mesocortical pathway, starting here in the midbrain, the VTA, going through the limbic system up to the cortex, all right? And this is a this is a dopaminergic pathway. And Ken has also done this with Ritalin, all right? So and because what it does is it blocks reuptake of dopamine sort of in this pathway. So it can act as an arousal agent. But what I was showing you here was this, where he's actually stimulating electrically, and he's also done it optogenetically, stimulating optogenetically the D1 neurons in the ventral tegmental area to basically turn the brain back on. So something in this space should work, and it's just a matter of now of doing enough human testing to get clearance from the FDA to carry it out. So what I've shown you here is these slow oscillations. All the anesthetics produce them. They produce them by different mechanisms, and as a consequence of what you're doing is you're probably taking away projections from the brainstem going to thalamus and cortex. That, I showed you the anesthetics have different signatures. They change with dose, patient age, and also the physiological condition of the patient. Like I showed you, that gentleman who had who had COVID pneumonia. And then closed loop control. The signatures are very reliable. They're very strong. They're very obvious. So building a closed loop control system is no big deal. And then reanimation. We should turn the brains of our patients back on, and because one of the things we should do it just in principle, but also because the drugs leave particularly elderly patients in states of brain dysfunction afterwards, and it can last from just a few minutes up to several hours or several days. So this is something which we should be doing. So if we could improve anesthesia care dramatically if we monitor. If we were to use closed loop systems, and then turn the brain back on after anesthesia. And then one final point, this is the anesthesiologist's view of clinical neuroscience. We're here in the middle, and all these things sort of circle around us, right? But the point is that there are all these cool connections with problems in clinical neuroscience that, we joke about, but we don't use to sort of improve our care scientifically. So for example, I mentioned how you can use anesthetics to treat epilepsy, turn the brain off. But actually at low doses, methotrexate will induce seizures, and alfentanil will also. We actually use that with ECT. Or just as another illustration, when animals hibernate, like the painted turtle hibernates, if you look at its EEG, it looks like burst suppression, because what it does is it amps up the amount of GABA it produces and also increases its sensitivity to GABA. So itself initiates this sort of state of burst suppression, which is hibernation state, and then it brings itself out. That's the key part, which would be interesting to understand. And as I mentioned, we use ketamine and actually several of the other anesthetics to treat depression. And also, as I said, you can use the Ritalin. I didn't mention this, but for coma recovery, my colleague Brian Edlow is carrying out a study on this. So if we were to pay more attention to what's happening in the other areas of neuroscience, we could come up very readily with techniques to improve neuroanesthesia, but also make what I think would be important contributions to these other clinical neuroscience. And ultimately, the patients will benefit. So I'll stop right there. Thank you. Oh, thank you
very much, sir.
My pleasure.
Talk. I'd like to just offer a small token of our appreciation for you coming to visit us.
Oh, thank
here
you.
In Cleveland. So that's
great.
for you.
Appreciate it.
We will have, I don't know if people can hear me online. We will have a reception afterwards. We'll take questions now. Those of you that are online, please put your questions in the chat. Those of you here, if you have a question, please raise your hand and Lisa will come with the microphone for the questions. So we'll take questions at this time. Mm-hmm.
So there are lots of drugs that work by enhancing GABA, right? Benzodiazepines, barbiturates, propofol. They seem very different in terms of their clinical effect. Are they more similar than we think when you look at the EEG effects?
No, actually, so that's a good example. So the benzodiazepines compared to propofol, they have different binding sites on the GABA receptor. And with that, if you measure the EEG, in fact, we just published a paper on this, or at least just submitted a paper on this. The EEG patterns under midazolam actually look like gamma oscillations. It's not nearly as potent as let's say like propofol. So propofol, the barbiturates, the etomidate, the inhaled ethers, GABAergic drugs, they all have exactly the same patterns. So, but the benzodiazepines are quite different because it's most likely due to the fact they have a different target on the GABA receptor. And they can't generate the same circuit dynamics.
I think it gets to the same areas in the pons and brainstem.
Oh, it clearly goes everywhere. I'm certain of that. But it's not powerful enough to sort of really hyperpolarize those neurons to the extent that propofol can.
So in the reanimation study that you showed last, I saw that there were 2 different frequencies at which you were stimulating. Are there any effects of the frequency on, I guess, like the level of rearousal or the level of consciousness achieved in rearousal?
I can't say we've studied that systematically, but I guess what Ken wanted to show was even at 20 hertz, he could also keep the, keep the animal awake, right? So there's probably a broad range, which we haven't studied, systematically. But the thing that this shows you is we made it so that, we implanted something in this animal's brain so we could turn him on and turn him off whenever we wanted to. And that's where we need to be, basically, for taking care of patients, being able to turn you on just as much as we want to, turn you off whenever we're ready. So that's why I did that. But we haven't studied systematically, but I bet it will be different for different stimulation frequencies.
Thank you for a very clear talk and interesting. I have a question. It seemed to me one of your job as an anesthesiologist is to maintain homeostasis while the patient is comfortable and conscious. And yet you didn't mention anything about the autonomic nervous system. Is it involved in it at all?
Well, very good question. So for the autonomic nervous system is very much involved, particularly for treatment of nociception. Because the nociceptive information, comes into the spinal cord. I mean, you know this better than I do. Comes into the spinal cord, has a first synapse, which is glutamatergic, then basically travels up. And one of the places that it stops is the nucleus attractus solitarius. And so that sends projections over to the nucleus ambiguus, the dorsal motor nucleus of the vagus, the parasympathetic pathway, and then also to the caudal and rostral ventral medulla, the sympathetic pathways. So when you don't have adequate anesthesia, when you don't have adequate anti-nociception, you'll actually see the heart rate and blood pressure go up. And that's how anesthesiologists right now figure out, do I give them more pain medicine? Do I give them more fentanyl or what have you? So in terms of, that's why I wrote the definition up there. What I'm trying to control right now is unconsciousness. All right. And if I just gave someone propofol, that wouldn't be enough for anesthesia. They would just be unconscious. And when the surgeon operated on them, their heart rate and blood pressure would go off the wall. Right. Except if you did it with ketamine. Ketamine is also analgesic, antinociceptive, as well as produces unconsciousness. So with the propofol, I run 2 other infusions of drugs to control nociception. So right, it's a different set of pathways.
Okay, that makes sense. Thank you. And I got another quick one. On the reanimation one, there's been a couple papers recently in large animals, pigs, that were being reanimated after a long period of hypoxia, more than 20 minutes.
Okay.
Can you comment on that? What is going on with that?
I don't know. I haven't read those papers, but I can tell you, in humans, as I said, my colleague Brian Edlow in the neurology department is actually testing the Ritalin out on patients that have had traumatic brain injuries. And I don't know if any of those patients had hypoxic injuries. I don't know enough about the pathophysiology of the brain state of the ischemic brain to really be able to answer the question. But one of the things that Brian has figured out, if pathways from the brainstem to the thalamus and cortex are still intact once the person's had the insult, then there's a good probability that once you give them the Ritalin, they'll come to. And so that's the state where we are now at the moment. So he's actually just finished his first set of patients, and so he's going to probably report out on that, pretty soon.
Okay, thank you.
Thank you. The use of EEG as a biomarker to control, to get a closed loop control of anesthesia. And other parameters like the heart rate, the blood pressure, and the oxygenation, etc. How do you envision to integrate all the biomarkers that are monitored routinely in the OR and to provide anesthesia that's the optimal, not only for the smaller bread and butter cases, but also for cardiac anesthesia, for example.
Okay. So, I mean, just getting to control unconsciousness will be like a giant step. Nobody's doing that, right? They're doing it in Europe, they're doing it in South America, but the FDA hasn't let us do it in the United States. So that's going to be a quantum leap, and I'm not exaggerating. I also have a student who's studying right now building a system to control blood pressure. All right, and so any patients that have arterial lines in, and they're in the ICU or in the operating room, you could control their blood pressure. And, you know, we've shown that we can if you just taking those immediate responsibilities out of the hand of the anesthesiologist, it's going to allow them to work at a much higher level. The same way when you turn on an autopilot, right? You know, the pilot can work at a much higher level, and you're more reliably tracking the patient. I mean, there's no way in the world you would update your anesthetic dosing every 5 seconds. It just doesn't happen. So I think just getting in place these two, or even just this first one, has the potential to substantially change practice. Then we can think about how we'd integrate and control the others.
Hi, you showed in the change in the brain waves for the sepsis patients, and I was just, in sepsis you get an increase in NO, and I was wondering if you thought maybe the NO was playing a factor there.
I mean, that's a good point. I hadn't thought about that, this increase in NO. Leading to the loss of the alpha, or contributing to the loss of the alpha?
Yeah.
That's a good point. The correct answer is I don't know.
Okay.
I'll go back and study that.
Okay.
Thank you. She's ignoring you, Bob.
I'll catch you later.
Okay.
You largely answered my question when you talked about the autonomic nervous system and nociception, but I was curious about the anti-nociceptive effect of anesthesia, and is there any effect on the EEG, for example, in a patient who is unconscious but does not have that anti-nociceptive effect?
Right.
What is the distinction?
So that's why the definition is really important. So all I worked on today was showing you how I generate unconsciousness. Okay. Then, as I was saying earlier, you have to give someone something to control nociception. So that would be something like remifentanil. It could be morphine, hydromorphone, one of the opioids, or ketamine, for example, or dexmedetomidine as an adjunct, to actually control the anti-nociception. If you don't do that, you just make the person unconscious, right? And then as soon as the surgeon makes the incision, the autonomic nervous system is going to go ballistic. It's just the heart rate's going to go up, the blood pressure is going to go up. And you realize that you haven't controlled nociception. You've just made the person unconscious. And in addition, depending on how strong the nociceptive system is, you'll actually see them. They could even start to wake up. And you see that because it's really cool. The spectrum looks like this, right? Alpha oscillation, slow oscillation. And what it does this. It opens like a zipper, because these go to higher powers, and the low frequency power gets lost. So you actually see the person waking up. That might be another, and that's really when you've blown it. I mean, because if you're just off a little bit in the heart rate and blood pressure goes up, you can just add the medication that you need. But if that's occurring, you need to practice a little more.
Is there any risk of if you were, because you talked about like separately controlling blood pressure, if you were separately controlling aspects of the autonomic nervous system, since those are like the markers for nociception, is there any risk of kind of disguising the effects of a pain response, and not having the same sort of markers to detect that there is adequate anti-nociception?
So you mean like by controlling the propofol, for example, you mean by using propofol to control unconsciousness, might I be hiding the anti-nociceptive or the nociceptive state?
Either that, or if you, even if it's a combination of drugs, if the drugs are controlling the effects of the pain response, like are controlling the increase in heart rate and blood pressure and that autonomic response, but not sort of at its root.
Right. I get your question now. So look, so here's the nociceptive system, and it connects with the autonomic nervous system, and that's how it tells us that it's not covered. So the drugs I was talking about giving are drugs which act here and shut this down, to shut that down. And just to contrast that, if I just gave the patient a beta blocker, right, the heart rate was slow. Hey, the heart rate's nice and slow now, so everything's cool, all right? But they would still be processing nociceptive information. You just block the output of it. So, but the drugs I was talking about giving here are drugs which would actually control nociception, and that's what you'd really need.
Thank you.
Cam has a question.
Yep, 2 questions online.
Okay.
Do you have a sense of how much variability you expect between different individuals in the accuracy of the model in predicting the depth of anesthesia?
I mean, so I'm very careful. I never say depth of anesthesia. So the level of unconsciousness, because it matters. I think there will be variability, but what we've learned from our monkeys is within about 3 to 5 minutes, we can figure out the parameters for that animal. So I suspect we'll be able to do something similar for humans. There will be variability for sure, but I think we can figure it out in real time and then sort of then tailor it to the person.
And then there's one more question online, and then I'll come. Normally, when you remove isoflurane anesthesia, there's a time period when the anesthesia is worked out before the animal fully wakes up. If you applied the stimulation after removing isoflurane, presumably the rat would wake up, but what if you then turned it off quickly? Would they revert to the state of coming back out from anesthesia, or would they retain the awake state from that point?
If I turn the isoflurane off, or turn the stimulation on?
You applied the stimulation after removing the isoflurane.
Right.
What if you turned it off quickly? What if you turned it off quickly?
Right. So what I did there was really just for illustrative purposes. What I should say that Ken did was just for illustrative purposes. What we would actually do is we would turn off we decrease the anesthesia until the person came out to a certain sort of a low level of unconsciousness, and then administer the Ritalin, let's say, or apply the stimulation. Because what you're trying to do is wake them up. And now you've turned off the anesthetics. You're letting them just come to. This won't work at all levels. Like if you put someone in burst suppression and try this stimulation or try giving them Ritalin, you can't wake them up. It's too deep. So you have to be at a stage where you're coming out in order for this to work.
One last question.
Great talk, thank you. I was wondering how likely other clinicians are to adapt this closed loop anesthesia approach, or have you seen any pushback from clinicians to adapt these systems, or have a lot of anesthesiologists seemed open to the idea of having more of a offline control of these things?
That's a good question. So in Europe and in South America, they're doing it now. It's just here in the United States where it's not happening because of, again, the stipulation that the FDA has put in place. I think people, the Europeans and the South Americans have been using computer-guided dosing for years. It's called TCI, and that wasn't approved either in the United States by the FDA. So I think once we have a challenge because we've not used the computer infusions the same way that the Europeans and South Americans have. So I don't know. I'd like to be optimistic, but I'm also realistic, having struggled with this for a while. We'll just put it out there and try to make it as available as possible and hope people use it.
And quick follow-up question. How likely do you think patients are to be open to the idea of having computer-controlled anesthesia versus having a human-controlled anesthesia?
Oh, so this is just going to control the unconscious for the moment. So think about it, right? If we were going to fly from here to Tokyo, right? The pilot takes the plane off. As soon as you get in the air, you turn it over to the autopilot. And the autopilot watches the flight information far more carefully than the pilot could. You imagine the pilot sitting there doing this, for 14 hours, right? It doesn't happen. So the patients are going to be better off. They're definitely going to be better. We have to make them robust systems for sure, but the patients are going to be much better off.
Thank you.
Wonderful. Let's thank our speaker.
Thank you.